My name's Brendan Furlong. I'm the Chief of Emergency Medicine at Georgetown. I practice clinically there now, and I started with MedStar Health at the hospital center in 1996 and have been Washington focused, but really now I'm broadening my experience by going across the system and joining the MedStar Medical Group. I'm working for Dr. Goldberg, our president, who is hosting tonight's presentation, as the Chief Medical Information Officer. And really, we're going to demonstrate what's going to be our new outpatient electronic medical record. And so I'm going to go through a series of slides now and try and tell you why are we here, what are we doing in this year. Our friends from Cerner are here. Cerner is the EMR vendor. It's one of the biggest in the world. They're with us here tonight, and they are our primary vendor for this system. We have IS colleagues, we have our physician informaticists here as well as other folks from the MedStar Medical Group. We're going to be very direct. We're going to tell you what the new system's not going to have. We're going to tell you that what's going to be sustained, what's going to be carried over from your life in Centricity. We're going to talk about the improvements. There are going to be some immediate gains that we have from this. We're going to talk about data that will migrate. We're going to talk about the rollout schedule. What is the schedule? It really affects us in our daily practice. We're going to talk about milestones in that. We're going to talk about the tactics, some of the things we're going to do to try and make this successful. Again, we go to the small subgroups, and we're going to have a video. And again, we'll grab some questions at the end, so feel free to mark them down and let me know what's on your mind. Why are we doing this? It's the burning platform. It's Centricity. We literally believe that we're about this far away. You can see that there's debris and probably some people in the water, but the actual platform hasn't burned up yet. It hasn't exploded. And so we feel like we have about 11 months now to get off of this platform. And so we're really, the mandate has come from our senior leadership at MedStar that we need to move off of that platform and really move into our new product. What is the product going to be? It's going to be a meld, okay? We know that there have been work groups working on this product on Cerner this year. We call Cerner MedConnect. They've been working throughout the year and starting to make design decisions. But a few months ago, everybody realized that for us to accomplish this build, we have to accelerate the process dramatically. And to that end, MedStar has entered a different relationship with Cerner. And so that we now have what is called model content at our fingertips. Model content is that material or that build information that is used at many places around the country. Intermountain Health, Banner, Carolinas, Boston Children's, lots of facilities that are using this product. Because we realize that we know we're special at MedStar, but we also realize people are doing this all over the country. And so we might as well take the collective wisdom of those who have built this system out before and use it. But we know that we want to meld that which is special, that which we've already done, with that content so that we can have a great product and get this done really to get off that burning platform. So it has to be compressed. For context, we probably spent about 10 years building Centricity. We're building this in about 12 months, 13 months. There's not going to be design customization at this point. That's one of our trade-offs. We just can't go into detail in each of the specialties. However, there will be personalization, and we're going to touch on this a little bit later. The Cerner product is much more friendly for individual user personalization than Centricity. It will allow us to really create things for us that are going to make our lives better. And so we're going to get into that a little bit later, but a key difference. So no product customization, but individual personalization is really where we're going to put our energy. Optimization is going to be the next phase. So this year, year one, 2016, is what we're calling phase one. Okay, and that's not an official term. It's just the way Dr. Goldberg and I like to refer to it. That is this rapid, get the platform up, get the code, make sure it's all solid, make sure the functionality is humming, and then, but take it as it is. Okay, and then next year, starting in January of 2017, we're going to start to do those things that we would like to do for individual specialties. Why do we think we can do this? It really has to do with a real rethinking and relook at this by the senior leadership at MedStar Health. So we're very direct, and probably too direct at times, but we're very comfortable with assigning responsibility. What's different now is that Cerner, they write and control the software. That's their product. we're also relying on Cerner to host the hardware. So our EMR is going to be living and running in Kansas City at Cerner headquarters. That's very different than what we have right now. So right now, we have GE software living in Plano, Texas on Dell Pro servers. And as you guys know, it can sometimes be very, very confusing. Is it the hardware? Is it the software when this thing slows down? And so hosting it and being responsible for the software is critical, and that's what Cerner, they are on the stick for it. They are a company, we are putting our eggs in that basket. Now, realize that you can't get from your fingertip and your idea to Kansas City unless you go through a MedStar infrastructure. So our infrastructure, as you know, has at times been challenged. We've grown very, very fast as a company, and we've had great variation from hospital settings to practice settings. And so what's going on right now is that our technical environment is being assessed. John McClendon is our CIO, and he's leading a group, including IBM, who's assessing from start to finish the MedStar infrastructure. So the PC, the mouse, the scanner, the network, the switches, everything that gets us to Kansas City and back. Okay, and so they're really looking to how we can optimize that and make sure that we can deliver function, in the way that it can and has been designed to do so. When I'm sitting in Kansas City, we were clicking at about 0.48 seconds when I was out there the last time, and that means that transactions were going across that fast. And I would say that, unfortunately, in our Cerner or our Centricity world, we don't have that kind of performance. We click, we get a coffee, we come back, and we see what happened, and hopefully we click the right thing. So again, we want to really, we're going to bank a lot on having a really sound technical environment. Success. I'm fairly linear when I think, and what we want, we like straight lines, A to B. There's no question that this year is going to be swirling around. We're going to do a couple flips, we're going to turn back, but then we're going to get to B. Because if you look on the x-axis, A to B, it's the same distance. It's not going to be that easy linear path, but we're going to find a way to get ourselves to B. What's out of scope? We're going to be very honest here. We're going to tell you the things that we'd like to have maybe, but are not going to be there when we go live. We are not going to be creating non-model content from now. So again, we're going with the model melded to the work that had been up to now, but we can't spend any time now doing customization of the product. Patient photos. Everybody thinks that makes sense. I certainly do. To have it come up as you look at your patient's chart, that's something that is very clearly sounds easy, but we just can't do it now. We'll do it later. Cerner has some very interesting mobile app and iPad-based uses and scenarios. We just can't do that kind of thing as well. Outpatient, we are not able to integrate all the devices that are in your offices. So when I say that, meaning like taking the vital sign machine and patient has the Dynamap do all the work, the numbers come up right now, people have to transcribe those into the record. Unfortunately, that's going to be the way we start. But in the future, the notion would be is that those kind of devices would be able to pass that information directly into the EMR, and it's called biomedical device integration. Gigantic work, as you can imagine, in the hospital, but also very relevant to the outpatient practices. That's not going to happen this year. That's going to be later. However, two things have been pulled out. EKGs, spirometry, those things are going to be integrated, and so they will be passed over automatically. Very difficult decision, but I think an appropriate decision, and it gets back to that burning platform, is that we need to leave the practices that are currently using alternative EMRs. We're going to leave them alone this year. So we have people using Epic in small practices. We have people using Allscripts, others as well. We have some people who are still using paper. Those practices are going to stay in that direction. In addition, another big chunk, we're a very heavy oncology system. Oncology in ARIA is going to remain functioning during this time. And so after, in the beginning of 2017, we will start to get those other practices up and with us. Again, part of this journey to get to a single record, but we have to bite off with that which we can accomplish this year. So those are out-of-scope pieces. What's going to remain the same? GE IDX, our primary registration system, that's going to be there. It handles scheduling, billing, that's going to be there. The current product of our patient portal, that will remain. In Centricity, a lot of people use a thing called Quick Text. That'll translate over to what Cerner calls auto text. LabCore and Quest interfaces, very important in many of the practices. Those will be in. Document scanning, same thing, that'll be in. I mentioned those two devices. And then finally, e-prescribing will be in as well. And e-prescribing will actually be enhanced, and I'll touch on that a little bit later. So what's dramatically new? Right now, although we are sort of, I'll call it dancing with Dragon and Centricity, it doesn't work that well. It works sometimes, it's just not that consistent. We're going to have a Dragon install that's totally different. It's going to be living in a cloud-based sort of scenario, and I'm not a great technical person, so if I don't want to misspeak, but basically what's going to happen is Dragon's going to be installed as Cerner installs Dragon in all of its major clients. And it's a totally different way. So it won't be worrying about is there enough server space down in Plano, Texas. It's going to be living with our primary system. And so it should function very well, and has been proven to function in other places very well. We're going to have a much more facile provider-level system, so of personalization. We'll have favorites, we'll have customized letters. We're going to show you many of those functions tonight, but really critical is that when we start to say, hey, we're going to be going live in your practice soon and you're going to get communication coming to you, this is the time where everybody has to check in. To me, it's a critical element. We're going to introduce things, we're going to do education, yes, but to me, what I found certainly on the inpatient side is that this time where you actually get in a room with somebody and really personalize the product for you can save a ton of time. And it really, we did that I can speak directly, we did it in the ER at Georgetown. It was huge, having folks creating favorites and kinds of order sets, things of that sort that really work and really make your life very efficient. Something that's different from the pharmacy side is that whenever you guys, whoever was around for the build of Centricity, lived through that very challenging piece of trying to enter pharmacies and having scripts bounce back, the paradigm is different now. There is a central database, a national database of pharmacies that is very mature. It's 10 years later. It is very, very easy in Cerner to pick out your patient's pharmacy, and you can save it with the patient. You can use these pharmacy tools much more efficiently. So to e-prescribe, as we need to, is a very, very easy process in Cerner. There are primary care tools that help support the patient-centered medical home. Our prompt cares, think of them as almost like little ERs in that they don't have scheduled visits, they don't function the way regular offices do, and so we're going to take some of our knowledge from our FirstNet or ER application, we're going to port that over. In addition, Cerner has a interesting thing they call semantic searching, which is almost like a Google for the EMR, and it really allows you to type phrases that will bring lots of information together about your patient. So you type in CHF and suddenly an echo comes up, and it really can help you hone in and be more efficient in terms of your practice. Most importantly, though, at the bottom, psychedelic green, it's a unified record. That's what really we're going towards, and that's going to be, to me, the biggest gain in all of this, and that we're not bringing everything at once. I talked about the limitations, but this is really the direction we're moving, and we're really taking a very big chunk in 1 year to try to get to that goal. Data migration causes tremendous anxiety, and it's something that we're working on very, very diligently. The very first piece, again, another, I'll call it Centricity sort of nightmare, was the time when we got an upgrade and all of a sudden we had duplicate records everywhere. Very, very challenging and very dangerous in my mind because we would have patients with more than one record. People worked hard to mitigate it. It wasn't for a lack of trying. But in this time, we've learned a lesson, and we're working very hard ahead of time. 500,000 records have already been added to MedConnect, on top of 800,000 that were already in. Again, remember, this is our inpatient EMR at many of our hospitals. Right now, perfect matches are happening almost all the time. Only 0.127% of the time are we not getting that perfect match. And what's happening at that 0.127%, I'm sure, is a lower number now because those errors, meaning that we don't have a positive ID, meaning multiple factor identification, what's going on with those are being worked manually so that we can get rid of those by the time they go live. And so very, very important so that when you call up your patient, you can be confident, this is my patient's record, and in Cerner, there's not 4 other records that are just like this that are describing the same person. So really an important piece, critical to data migration. You got to know where to land the data. We're going to be porting over things like vital signs, lab results, radiology reports, problems, allergies, immunizations, and medications. I'm going to talk in more detail about those. However, basically we're bringing over a lot of data, and we're going to bring over whatever we can in a discrete fashion. There will be some kinds of data and some kinds of reports that we can't do that are going to actually come over as PDFs, but happily, along with our clinical notes, those are going to be organized in a way that aren't just a dump of data. They're going to be in folders, and they're going to be in a reasonable way. Key kinds of notes that we will bring over: office visits, procedure notes, EKGs. And I put that little asterisk at the bottom. And behind this slide, I'm not sort of hiding anything. We have 46 note types that we're porting over, okay? And we have various ages, various numbers of years that we're going to look back. We have to prioritize. Obviously, you want to start with present time and go backwards in terms of the documents you're porting over automatically. And so we're going to be doing that, and we're going to use our best judgment to bring over the most that we can that makes sense clinically. But know that those things that we can't get over are going to be living in Centricity. And eventually, Centricity is going to become a read-only database, and then we'll be able to manually port those over. So they're not going away. We're not throwing out the records, but we'll be able to bring them over. Probably an important point to make, although I don't think we have pediatricians tonight, is that for pediatric patients, we go all the way back. For adults, we tend to go back 1 to 3 years. And for certain kinds of documents, we're going to look how can we possibly go back further and bring them over and port them. So this is a very, very complicated project going on right now. It's going well, but we'll definitely keep you up to date on the kinds of things that you'll see whenever we go live as they are migrated and confirmed to be into the system. Again, key note types with a reasonable look back. Centricity is not going away. And again, we can move the documents over. If there's something that you're worried about that doesn't get over, we can look back. Okay, data reconciliation. This is an important step in this process. And I'll speak to some places that I visited around the country that have unified records. One of the challenges of unified records is etiquette. And how do we take care of lists that are critical, like problems, medicines, and allergies, and immunizations? If you can imagine if 800,000 patients are living on our database now, and they have problems, meds, allergies, and immunizations, and we bring over maybe those same patients described in about 500,000 instances, there's no chance those lists are going to be the same. We know it when we're practicing. You know, we could have somebody who's seen in an oncology clinic in ARIA. Oh, guess what? They had a baby last year. They're in Perigen. And oh, guess right, they got their internist who's taking care of me in Centricity. And suddenly they had a hospitalization and they're in Cerner. So nobody is kidding themselves to say we are perfect in reconciliation of these lists. However, as we port over from Centricity to Cerner, we're going to take a stop moment. It's what I call a necessary reconciliation. And it will allow us to take that moment and sift through those problems, medicines, allergies, and immunizations, and make sure that we get a good, accurate record to start. Now, Cerner has a great tool for this, and we know that on some patients it'll be a 2-second thing to do. Oh, they only had 1 visit, it's not much. Some will be a complex transplant patient who has 18 medicines that we have to sort through. We know that that's going to be a lift at the beginning. We'll plan ahead of time, plan in your schedule ahead, work with your medical assistants if you have them, work with the folks, but really take that stop moment. Cerner will present a list on the left side, which has those things which are ported over from Centricity, and then on a click basis, we will be able to send those over to be part of the new chart. So, again, has to be done in part because we don't want to bring just garbage into an empty record, but on the other hand, we know that many of our patients are going to already have existing records in the Cerner system, so we really have to take that moment for what I call a necessary reconciliation of those critical data elements. So milestones in the project. Right now, we're here tonight, content demonstration. So that's going to go on for the rest of this month. There's a ton of work going on behind the scenes. We're up here, working with clinicians to show them what's going on. Next several months, communication, updates, Dragon pre-work. There's it's definitely known that if people spend time in Dragon ahead of time, when you adopt an EMR, you're going to be way better off if you haven't used it before. And even if you have used it, creating content in Dragon can make you a very much more efficient person in documentation whenever we get going in the live system. When we look at the go lives, we're going to say, okay, let's go about 2 to 6 weeks because of retention purposes. We're going to go 2 to 6 weeks back, from the moment that we're expecting to go live, and then we're going to start to have really intense focus on you as providers. And so we're going to be coming out. We're going to be trying multimedia, different kinds of educational techniques. I mentioned those before, and that's when that's going to happen. So you'll see when we put up the calendar, what you should start to expect in your practice, and again, start to plan for. When we go live, we're going to have continuous, robust at-the-elbow support. We know that this is going to impact your first day. No matter how much we prepare, how much we train, when you haven't worked in a system, it's very, very difficult. And so we know that that's going to be a challenge. Our goal is to make the first day a non-event, but we know we have to have support. And so you're going to have folks who are in your office helping your office staff, helping you make sure that you can get through the day and use the tools and start to develop a comfort level in documenting your care. So provider efficiency monitoring, this is something that's a little bit new, and it's a technique to help us really help the provider who's struggling. And what it is actually, Cerner can drill down to the level of you, to the level of the user, to figure out how long you're taking to get certain tasks done. So if somebody's taking a giant meandering pathway to get a CBC ordered, we should be able to pick that up based on the transaction. We're going to know who's working late after night. They call it pajama hours, and I think that's in a future slide. It's not meant to be Big Brother watching you. It's not somebody trying to say, are you really at work? Are you doing your job? That's not it at all. It's to try and help you do a great job and be efficient. So this is the schedule. Small print, not to be deceptive, but just to show you that it's a very, very rapid turn. May 16th, pediatric locations, Federal Hill up in Baltimore, all the way through, outpatient practices, coming to the end in Washington at Hospital Center in Georgetown by December of next year. So it's going to be a very, very rapid. You can see there's really not much of a gap in any of these sort of what we're calling pilots and waves. The most important thing is to say May 16th to December 5th is where we're scheduled to have all of this work done. How was this schedule made? Very complicated process. A lot of really smart people thinking about all of the different pieces of this. Very important to think about is the practice considerations. Think about providers who are moving between clinic sites. There is the chance, and there are some providers who are going to need to work in different EMRs, during this period. So they're going to need to work in Centricity one day, they're going to be in Cerner another day. It's not avoidable, but the schedule was made to try and minimize that. Residents come. We have a whole new force of folks. A large number of people are going to need to be trained. And so we try to avoid some of those academic sites as best we can in that early June piece. We can't avoid it. There's no perfect way of doing this, and there's no perfect way. But what we try to do is minimize the impact on the providers as logically as we can. Due to the complexity of Hospital Center in Georgetown, they represent right now about 78% of the people, not of all MMG, but of the people who we need to migrate over to Cerner. So 78%. Very clearly, we need to put that towards the end whenever we have gotten some experience with some of the smaller practices. Proximity and logistics, really important for our IS colleagues in Cerner. We can't have them driving from Alexandria to north of Baltimore to try and support somebody who needs help. We have to have them proximally located. They're going to be at the elbow, but then we're also going to have folks who are centrally located in terms of command centers who can rapidly respond if something is necessary and who can really be there to help out. So we really need to use our staff well, and that includes our IS, our Cerner colleagues, and really our informatics teams as well. Kind of scary numbers from my perspective. 2,700 providers right now, 3,500 non-providers, 184 billing addresses, 283 suites, and 85 zip codes. That's what we're going to do this year. So it is a very big project. And so, and that's why all this complexity is what led to that schedule. So is it a perfect schedule from every single person's perspective? No way. But is it really the best we can do? Yes, I believe it is. Optimization. We talked about that. That phase that starts in January. So in January of 2017, we're starting that process right now, by the way, tonight. Because tonight, when you're off in the rooms working with and seeing folks show the content, we're going to be taking notes. We're going to say, we know we can't promise this to you now, but we need to get a list. We need a good list. A list that we can triage to say, what can we do starting in January of 2017 to get this product customized in a way that will help you in your practices become even more efficient. How are we going to do it? We talked about the dedicated resources. The Cerner resources are here. They're not going away. They're going to be with us. Another important key piece that I think is going to help out and which will be different is that we're going to greatly enhance the number of physician informaticists and provider informaticists in our system. Those are folks who have a very, very unique and interesting skill set. They are able to listen to you clinically. They get it. They are working in the hospitals. They see what it takes to get a patient to the OR. They're there with you. And yet they have a depth of technical knowledge that they can help translate over to our IS colleagues. Nothing is worse when our IS colleagues have no idea what to build based on what the clinician says. You know, you have a gap, there's a communication gap. The informaticists are critical in helping to bridge that gap because, again, they translate over what we're saying clinically and they help turn it into something to say, hey, let's build it this way. Another important piece of this is IS. IS is redoubling its efforts. It's looking at what we did in the past and what we can do to improve the model, because the model of how we actually get from the idea of a provider or a group of providers to something being up and working in the system is a very complicated process. Our IS colleagues are critical to that. They will be working very closely with our Cerner colleagues to make sure those things happen. Another important piece of this has to do with MMG. So the MedStar Medical Group is brand new. There's only 3 clinical councils stood up right now. By next year at this time, we expect 21 clinical councils to be running, and those are our specialty councils. What's really essential when you're working in a shared EMR is that you have unified decision making. So Dr. Goldberg has asked that each clinical council has an EHR subcommittee. Those are going to be physicians or providers who are dedicated to the EHR in terms of helping us develop it. And by definition, they're going to bring the voices of the providers together. That's one thing that's very, very difficult. When you have providers meeting in a room for the first time on a computer build, it never works. You have strong personalities, you have different ways of doing things. That work and coming up with what the real things we need to measure, to create in the EHR is going to happen with those EHR subcommittees. Those are in development, and so again, by 2017, they're going to be a very important part of our governance structure around the outpatient EHR. Again, we also have things that are working well. In our current inpatient MedConnect world, we have processes led by Joel McAuliffe, our CMIO, that have really led to us having very nice enhancements in our live system. And so every Monday there's a call. Ideas that have been vetted, brought together, tested, and built go through a final check, and then are put into production. And it's really, if you look at the list over the years, a tremendous amount of things have been done to the system since we went live. And so really we're going to build on what those things that are working well, and we're going to morph those for the outpatient world. So that's product optimization. So we're going to go to a quick video here. We're going to show a video of one of our internists, a doc at MedStar, who is facile in the system. She came to us fairly recently, but has been working in a mature Cerner system with the content that we have. And so she's going to give you a quick run-through of what you can do, not to say the whole visit, the video is only 8 minutes, not say a whole visit is that long, but to really say, hey, here's what you can do in the documentation side once you get to be pretty good at that tool. And then we're going to break up into smaller groups, and we're going to go to, some will stay here, and then we'll go into another room where we will go through a much slower paced review of the content that is built and make sure that you can understand certain key functionalities, things that you're going to need to do. This is not your educational session. This is getting you used to the content. This is us saying, here's what it is. Look, it's the dynamic doc tool, which is what really the basis of the primary note generation in Cerner, is very, very different than what you do today. And so we need to get you used to that and to see that so that you can then absorb it and see it again later and then start to develop skills in creating notes that way. So let's go ahead and roll the video.
Hi, I'm Susan Locke, an internist at MedStar Health. In this video, I'll introduce you to the ambulatory physician workflow in MedConnect. Follow me as I demonstrate how quickly and easily physicians can access a patient's record and begin charting through 2 patient scenarios. The first scenario is that of a new patient visiting a primary care physician for a well adult exam. The second scenario is that of an established patient seeing their surgeon for a follow-up visit in the clinic. Let's begin with the new patient primary care visit. Note patient Daniel Harris shows a status of seen by nurse, indicating that he is ready to be seen by the provider, and room 102 is marked so we know where to go. On my provider workflow page, I am able to review the patient's medical history, which was documented during intake with our clinical staff, and begin the creation of my note as I go. I see in the Documents section the patient had an emergency room visit. I can review vital signs, problem list, allergies, and home medications. I can view the medication history, which was documented during intake, and other pertinent histories, including procedure history, family history, and social history from this page. I can review any pertinent labs or diagnostics. I see he had a CT scan with IV contrast, and any pertinent pathology results. Next comes our recommendations section. I can see from this section the patient is due for the influenza vaccine. I can order directly from this page. Now I will begin to document my note. Next, we move down to the review of systems. At this point, we can use auto text. And next, we're ready for the physical exam. Again, we can utilize auto text in this section. I am now ready to place orders for this visit. I will move to the Quick Orders and Charges section, which is meant to mimic a paper super bill. It's a new patient, level 2. Going to order some labs, CBC, CMP, and lipid panel. I will move to the Consolidated Problem section and move hypertension and hyperlipidemia to this visit. In addition to need for flu vaccine. Now I am ready to sign off on my orders. I can now complete my medication reconciliation. I go to outpatient. And begin the reconciliation. The patient is asking for a prescription of lisinopril. I can order directly from this page. Now we see that our medications have been reconciled. Next, I move on to patient education to give him materials to help manage his hypertension. Now I will bring all of my documentation into a final note. I can review my note, enter information into the assessment and plan, and sign my note. To complete the visit, I will review the visit summary that they can take home. And now we are ready for the next patient. And that concludes scenario 1. Now that I've documented a primary care visit, let's move on to the second scenario, where I'll create a post-op note for an established patient following surgery. Note patient Daniel Harris shows a status of seen by nurse, indicating that they are ready to be seen by the provider, and room 105 is marked so we know where to go. On my provider workflow page, I am able to review the patient's medical history, which was documented during intake with our clinical staff, and begin the creation of my note as I go. I can review the emergency room visit, when the patient had the appendicitis. I can review vital signs, problem list, and home medications. As the surgeon, I did not prescribe these medications, so I can simply click Acknowledge Remaining Home Meds and reconcile and sign. Review any additional histories, labs, and diagnostics, as well as any pathology report. Now I am ready to document my note. If review of systems is indicated, I can utilize an auto text with a brief review of systems. Moving on to physical exam, I can also utilize auto text for a post-op wound check. Now I am ready to place my orders and charges from the Quick Orders tab. I scroll down to locate the appropriate charge and move to the Consolidated Problems to enter the appropriate diagnosis. And now I am ready to sign off on my orders. Next, I would like to provide my patient with educational materials to take home. And now I am ready to begin my note. Once I review my note, I can complete the assessment and plan. I am now ready to sign my note. I am able to forward the note directly to the patient's primary care from this page. To complete the visit, I will review the visit summary that they will be taking home. And now we are ready for the next patient on our schedule. As I've shown, starting from the provider workflow page, you can quickly and easily access a patient's record to chart in the clinic setting. For more MedConnect videos, visit the video library on the MedConnect Starport site.
A couple of things I think that are apparent in the video that I wanted to point out about the flexibility of the system. You heard terms like smart text, Dragon. She didn't say that, but she was typing, but you could use Dragon, so really it adapts to what works best for you. So you can use different tools within this, and it will really, in my view, help you to personalize the system for your benefit and for your efficiency. So thanks again, and we'll break out, and thanks for coming up.